so as Lucy said, I want to talk today about the health economic analyses we did as part of the PopART trial, but also more broadly, really about the economics questions that we were thinking about. I will talk about, not quite like the title is, I changed my mind last minute that instead of quality of life, I talk about productivity and inequalities in access to care, and then of course the cost effectiveness analysis. And I'm presenting on behalf of the PopART economics team and also, of course, the wider PopART team. Now, first I want to introduce really the people who have been working with us over the many years that we were working on this trial. Collaborators from the UK, from Imperial College, but of course our Zambian and South African colleagues with us all the way, and Christoph Fraser and his team making incredibly valuable contributions to our analyses. I want to talk really about the program of work on the economics of HIV and the impact assessments that we did for universal test and treat using the data that we collected as part of this major study. I want to present today the studies that I have underlined here. So the first one clearly is the main piece of work that we did, and it's not only the costs of the trial, but actually the societal value determined with the cost effectiveness analysis. And the lead author for this is Ranjita Thomas, who I think set the gold standard for integrated economic epidemiological modeling in this field by doing this study. Now, the cost effectiveness analysis, or CEA, that we did from a health system perspective, which is perfectly valid. However, it neglects important societal impacts that we tried to assess with a few additional studies. So we did studies on health-related quality of life, led by Ranjita and now by Catherine, PhD student of mine, on productive days lost, which I will present quickly today, led by Julius Ornberger. Inequities in healthcare utilization, so using economic tools to actually quantify the impact of inequities, led by one of my PhD students, Krista Hansen, and also contributed by my colleague Marisa Meraldo. We also have studies on hospital utilization, led by our South African colleague, Ronelle Berger. We looked at variation in intervention costs across communities, which we found were high, trying to understand the reasons. We are not quite there yet, so maybe that I can present to you next time. And then impacts on informal care. Now, in doing this analysis, we not only wanted to inform about these additional impacts, but we also wanted to generate estimates that are useful for researchers after us and for studies after us to use in their analysis. So we tried as far as possible to prepare the data in a way and have like massive appendices with tables that would allow researchers just easily to use our estimates for their studies going forward. So first, I assume that probably you know about the PopART trial, but I will just give a super quick rundown of what the HPTN071 PopART trial was about. You can read the key publication in the New England Journal of Medicine. The link is here. And of course, there are many, many other publications led by Richard and others. So UTT was proposed as a strategy to achieve the steep reductions in HIV incidence that we didn't quite see from over the past decades, despite concerted efforts in the countries most affected. But the question was always, can it be delivered in practice in generalized epidemics? And what impact on HIV incidence can actually be achieved in the real world? Now, the study took place in Zambia and South Africa. We had 12 communities in Zambia, 9 in South Africa, and there were 2 interventions arms, A and B, and 1 control arm, C. And it was a cluster randomized trial where basically triplets were generated in order to allocate communities randomly to these 3 arms. And the total population covered was enormous, about 1 million. The study design, Arm A, is the full PopART intervention, including immediate ART, irrespective of CD4 count, so immediate initiation on ART. Arm B is a bit complicated because it is the PopART intervention, except that ART was provided according to current national guidelines, which changed over the course of the trial as a complication. So initially there were some CD4 thresholds, which later were lifted. And Arm C was enhanced standard of care, including also ART according to current guidelines. The primary outcome was measured in a random sample that was drawn from each community, which was younger adults, assessed in a population cohort that was followed annually for 36 months. There was one baseline called PC0, and then we had for each year PC12, PC24, and PC36. So these are basically the data that we generated from that. The cohort is about 52,000, with attrition, of course, and problems related to that. The intervention was provided by community HIV providers that we called the CHIPs, and they delivered a door-to-door intervention where people were tested for HIV. They were also retested, and if they tested positive, were referred to the clinic to be initiated to care that was delivered in Arm A and in Arm B. In Arm A, they received immediate ART. There were then repeat visits to clients living with HIV, and also other prevention interventions were also provided, listed on the left. So the study timeline is a bit complicated. We had the CHIPS interventions, round 1, 2, and 3, between the end of 2013 and 17. The survey that was conducted from randomly selected participants, which was repeated 4 times, as I said. And then we had in Arm A, universal ART all the way through, whereas Arms B and C, as I said, the CD4 count threshold changed according to national guidelines, and to make things more complicated, even they were different in Zambia and in South Africa. So that basically for the later part of the trial, there was universal ART all over, and effectively the trial became a trial of universal testing. So what have we shown? That it's feasible and acceptable to deliver such a community-wide HIV service, that PopART very successfully, due to the enormous effort of our country teams and the wider PopART team, the UNAIDS 90-90-90 targets, with impressive viral suppression targets reached, and that over 3 years, population level HIV incidence indeed was 20% lower in Arms A and B than it was in Arm C. And also there were viral load reductions achieved that were consistent with the expected effects on HIV transmission. Now the question, of course, is, so it's great that this intervention was shown to be effective. The question, though, is first, how much does it cost? And the second question is, what is the societal value of this? Is it worthwhile for policymakers to implement that in countries? And this was the objective of the cost and cost effectiveness analysis of PopART, with the lead author being Ranjita, and of course supported by the rest of us. The paper is published in Lancet Global Health, where you can read all about the details of it. The background, so what this analysis required was a very close integration of the epidemiological model and the cost effectiveness analysis. And Will Prorich and Raphael Sauter at the time made enormous contribution in working with us and working with Ranjita to achieve this close integration and come up with very innovative solutions to problems that we didn't even know existed when we started out on that journey. We have 2 projection scenarios, which you can see in the box below. So with the first intervention scenario, because it was based on a modeled analysis, both of the trial intervention arm and the standard of care arm, we looked at what if the PopART intervention was implemented in 2014 as it was, but then continued in annual rounds until the year 2030. Whereas in the counterfactual, we have standard of care. So we looked at both the cost impacts and the benefits measured in reduced infections. So that was the first intervention scenario. And the second intervention scenario was just the actual trial. So basically PopART delivered between 2014 and 2017 in 3 annual rounds and then discontinued, replicating the actual trial. Again, we projected the impacts until the year 2030 in order to see any delayed impacts of the fact that the trial had taken place in these communities. So we did this from a health system perspective, and we did extensive uncertainty analyses around our key parameters, both arising from the epidemiology and also from the costing analysis. We did a micro-costing study, so that means we, and these were really our country teams, visited each and every facility in the study community to collect the costs that there were to provide standard of care. And of course, we also looked at the costs of the CHIPS intervention, so the PopART intervention itself, by using our own financial expenditure records of the trial. And we looked at the cost of HIV testing and treatment and BMMC and all the other prevention components that were happening in the intervention communities. We also did a time and motion study to disentangle the costs of CHIPS activities. We did this because with these types of interventions, salary costs are so high that it makes sense to spend a lot of time actually studying what are the different cost components or the different activities that staff spend their time on, and that helps with later others reading and generalizing the studies to other settings. We also had secondary data sources for some cost items where we just didn't get the data. The benefits were collected in terms of infections averted, as projected by the EPI model, by the individual-based model. And we also converted that in disability-adjusted life years or DALYs. And we did that because we wanted to assess both the impact on mortality and morbidity of the trial. Now here is just an example finding from our time and motion study, which I think is a reminder to everyone to look at the cultural context and the social context in which interventions are delivered, because here we can see, for example, the time it takes a CHIPS person, so one of our healthcare workers, to consult a client who had a positive HIV positive test result, and we can see and the HIV negative test result, and we can actually see that in Zambia this time for both the clients was much higher than the time it took in South Africa, and this is just a reminder really on how deep-rooted the problems are of generalizing results to different settings. Now, here is, by the way, I've forgotten to say that please interrupt me or ask questions in between if you have questions. I can't monitor the chat despite my 3 screens, so please just barge in if you have a question. So here you see the projected HIV incidence from the PopART individual-based model between 2010 and 30, matching to our 3 scenarios, being the actual trial, 2014 to 17, the projection until 2030, and no PopART. And I think what we can see is that if for the actual trial, we have a positive impact, but over the 10-year projection horizon, that actually approaches then again the standard of care. And that applies to both countries and to both men and women in this trial. So here, of course, projected is, incidence per 100 person years. So here you see the estimated costs of us for standard of care. So why is this estimated? It's estimated because we have, of course, an underlying assumptions about how the population grows and other things that we got from the IBM. So here you can see basically the estimated costs for standard HIV care. So this includes testing, treatment, ART, VMMC, so male circumcision, delivered at the healthcare facilities in the PopART communities. Now, it excludes costs related to screening for TB and STDs and some other things. But we will add that later. So the estimates are, as I said, influenced by population size. That's why they're higher in Zambia than in South Africa, because just the communities were larger in Zambia than in South Africa. And also we have a more steep population growth in Zambia than in South Africa. That's why these costs are increasing, and they are here not inflated because we wanted to show the actual costs for the policymakers to consider. So this is standard of care. This is if we would not be doing a PopART intervention. And now in the blue bars, you can actually see what are the annual costs of the PopART intervention were delivered to the year 2030. So this includes the cost of standard of care. But we can see that the PopART intervention or the CHIPS intervention, the universal test and treat, adds nearly double the costs to the normal standard of care. So these costs include the CHIPS activities relating to HIV testing, linkage to care, referral for male circumcision, counseling and adherence counseling. It includes administration costs, training, communication, work-related travel between facilities for the CHIPS workers, and related costs. We have this steep increase in the first year due to because it took some time for the trial to be properly implemented. We can also see these costs. These are now the incremental costs over and above standard of care. So this is if a policymaker would want to have annual rounds of PopART intervention delivered until the year 2030, on top of what the policymaker has to pay for standard of care. This would be these amounts for Zambia and for South Africa, considering, of course, that the annual population, the average annual populations would be impacting on these costs. We can also see here the cumulative costs by category for our long-term intervention scenario until year 2030. And I think, again, these costs are undiscounted to show the budget impact to policymakers who plan a potential implementation. So the differences in costs here, and that needs to be considered, reflect both the difference in unit costs and in population sizes, and of course the projected growth in communities. That's all worked into this. I think what's striking about this graph is that the ART costs, so basically the normal costs that are delivered at the facilities are actually higher in the intervention communities than in the standard of care communities. So the orange bar is higher in the intervention than in the standard of care communities. I mean, what does it mean? It means that PopART is not cost saving to the healthcare system over this projection horizon. So anyone who thinks that due to the reduction in incidence, we have reduced healthcare costs is unfortunately disappointed. Due to the higher testing and the successful linkage to care in the intervention arm, this implies that more people are on ART for longer, which results in higher costs overall. So, to save costs, nobody's doing PopART in order to save costs. So, and that is not really the question to ask. The question is, what are we actually buying with these additional costs? How many life years are we actually saving with these costs? And going further, if we were to spend this money on PopART compared to another intervention, for example, an intervention for improved detection of TB or an intervention for non-communicable diseases, how much life years would we be buying if we were to invest it into PopART versus investing into TB or, let's say, diabetes interventions? So that's really the question to ask. And this is what we are trying to answer with the cost effectiveness analysis. So the cost effectiveness analysis essentially looks at what are the additional costs of PopART and what are the additional benefits of PopART compared to the usual standard of care. And this is what we get answered with this summary measure of an ICER, or an incremental cost effectiveness ratio. Here are the ICERs, or the incremental cost effectiveness ratios, for Zambia, for South Africa, for our two intervention scenarios, so both the trial and the until 2030 implementation, and both expressed in terms of infections averted and in terms of DALYs averted. We have here the median estimates over 1,000 simulations and a 95% credible interval that comes from our parameter uncertainty related to epidemiology and costing, key costing parameters. So we can see that the in terms of infection averted, for example, the way we interpret this is that to avert one infection, we would have to pay $2,272 if we were to implement the PopART intervention. Now, the ICER is slightly more favorable for the shorter PopART intervention for the actual trial, because if we were to implement the actual trial, we would only pay 1,220 in Zambia to avert one infection. Now, there are, of course, many different estimates going into this, but in summary, the trial ICER is lower because there is a sustained positive impact on incidence that lasts beyond the trial period, but there are no intervention costs beyond the trial period. So because of that sustained impact, we have more benefits, more incremental benefits than incremental costs, and that's why the ICER is slightly lower. However, as we saw previously on that graph, incidence does approach the standard of care once you get to 2030. Now, it's problematic to compare, although I've done it now, but I shouldn't really do it, compare ICERs across the different intervention scenarios, because of course both ICERs are formulated with respect to standard of care and not to each other. Right. Okay, so the results can also be shown in terms of a cost effectiveness plane. So anyone who ever sat through a health economics lecture will recognize that we are in the top right quadrant of the cost effectiveness plane, meaning we have higher costs and we have also higher benefits. Which means that we need to ask the question, what is a policymaker actually willing to pay for a DALY averted in order to decide whether this is worthwhile to implement or not? So here you can see also the median estimate and the different estimates related to coming from our simulations accounting for uncertainty. So in order to answer the question, whether the intervention is cost effective, health economists have resorted to the answer, it depends. So it depends on the willingness to pay threshold of a policymaker. And that's why they come up with this cost effectiveness acceptability curve, because here we say basically to the policymaker, depending on your willingness to pay, for one DALY averted, we can tell you what the probability is that this intervention is cost effective. Of course, the more you're willing to pay for a DALY averted, the higher is the likelihood that the intervention is cost effective. And so we can see here that a low willingness to pay thresholds, both in Zambia and South Africa, of around 500 per DALY averted, the intervention would not be considered cost effective. But if we get to at least for the longer scenario, however, for the trial scenario, it would be cost effective. However, of course, the higher the willingness to pay threshold goes, the higher the probability that the intervention is cost effective. So this is how economists get out of making a definite judgment on cost effectiveness. There used to be in olden times a criteria that WHO came up with, that the cost effectiveness threshold should be GDP per capita. That is not anywhere found on their website anymore. But if we were to apply the threshold still now, then PopART would be cost effective in both countries. Now, there are some clever people, though, colleagues of mine from York University, who have actually looked at past decisions of policymakers and derived empirically a threshold value that was implicit in adoption and non-adoption decisions. And if we were to apply these thresholds, then PopART is cost effective in South Africa, but not in Zambia. As I said before, PopART is not cost saving to the healthcare system, and the value of PopART arises from the improvements in population health. Of course, affordability is a super important consideration. Also, I think very important in future research is to look at alternative implementation scenarios, and also think about some of the parameters that we have assumed for our projection horizon, which of course is slightly heroic in many cases. We assumed they're constant over the projection horizon. We didn't assume any technological innovation in diagnostics or treatment, no changes in price list guidelines, or we also didn't assume that there would be a behavior change. Of course, this is all slightly unrealistic. With some of the additional analyses that colleagues of the economics team have done on other variables that we and other data that we collected during the PopART trial. So one of them is the impact of the intervention on productivity, led by Julius Ornberger. So we know, of course, over the history and still now, that HIV has a massive impact on the economic welfare of households, communities, and then by extension, countries. Economic growth has been shown to be linked to HIV and to increases in efficacy of treatment. Also on the microeconomic level, there have studies been done that see that even after the arrival of effective ART treatment, that there is often a dip in productivity around the time of initiation, together with the reduction of CD4 count and an increase in the viral load, so people becoming sicker before they go on treatment. And this dip in productivity has been estimated to be around a 1-year dip in productivity. Now, that might not be sounding so bad, but for one individual, but of course, if you see it for a whole population in a high prevalence country, that is quite an impact. And also, of course, it might entrench unemployment or other problems. So we had one question in the PC surveys that was whether in the last 3 months, an individual lost any days of productive work, of their usual work, due to own sickness or due to seeking healthcare. So based on that, we formulated a study on productive days lost, or PDLs. And of course, this was both work at home and work in gainful employment. Now, actually, the longer we thought about it, the more complicated it became, because UTT could have complex effects on PDLs. Well, first, of course, UTT diagnoses people living with HIV earlier and links them to care earlier. So we can hope that this dip in productivity is prevented. So if we prevent a dip in productivity of 1 year, that's actually quite a lot if we aggregate it up to the macro level. Then, of course, UTT prevents new infections, as we have shown in the overall results for the trial. But it's questionable whether that would show in productivity impacts over the relatively short observation period. However, on the other side, so these are good things, but on the other side, universal test and treat makes people living with HIV visit healthcare centers more often. Now, of course, you would say that is a good thing, but for people who are living in informal employment and who don't have like legislated sick days, that means 1 day of work and 1 day of employment lost. Potentially, if they have to wait and travel to the healthcare facility and wait there for a long time, as we know many of them have to. So that could be actually a negative impact, at least in the short term. And then there could be some spillover effects in that a healthier population, HIV population, reduces the informal care burden for friends and family, and they can be more productive at work. So the parameter of interest is the mean difference in PDLs between trial arms, and we have a two-step approach as developed by Richard for cluster randomized trials. And we did this by the 3 post-intervention surveys, PC 12, 24, and 36. So first, we risk-adjusted outcomes by important observables from the baseline. And we used a negative binomial model to predict the outcome PDL, which was strongly right-skewed. That's why a negative binomial. And then we used this to generate a residual effect. So from the first stage, we computed the expected PDLs in each cluster, and then computed covariate adjusted difference residuals by taking the difference between the observed and the expected PDLs in each cluster. And then in the second stage, we basically generated a point estimate of the intervention effect, meaning the mean difference that is obtained by comparing the mean of the difference residuals between the intervention and the control arms. And we did this also to assess heterogeneity by HIV status, by age, and by gender, which I will not present. I just present the overall results. So here you see the estimates of these difference residuals, so basically which tell us what is the difference across for HIV positives in the top panels at the 3 different post-intervention surveys, and at the bottom panel for the HIV negatives to look at any spillover effects. And this is comparing intervention arm A and arm C. And we can see that there is clearly a reduction in PDLs in arms A, in all but one triplet. One is always an outlier, but there is a low, and there is a low mean variation between triplets. In PC24, there's also a reduction in PDLs in arms A, in all but one triplet, confusingly a different triplet, and a higher mean variation. And when we actually estimated the quantitative effect with our, by conducting appropriate statistical tests, we found that the PDLs were less than a day lower in arm A. And that was only in PC24, 0.87 days lower. PC36, no clear direction of impact and no spillovers, as I said. So this was comparing A and C, and now we compare B and C. And we also find a reduction in PDLs, but this time it was in PC12. And the effect was very similar, 0.79 days lower in the intervention arm B. And again, we find some variation in impact, but there was one. No spillover effects and nothing significant in PC24 and 36. So clearly, the positive impact of UGT on productive days prevailed over any kind of negative impacts that may arise from individuals visiting healthcare facilities more. So there was clearly a positive impact, potentially explained through the fact that individuals were healthier and therefore more productive at work, which is great. So that was the first study we did, and which is not published yet. And then we have a second study, which was led by Krista Hansen, PhD student from the Imperial College Business School. And this is joint work as well, mainly with Marisa Meraldo, but also the PopART team, of course, more widely. And there we looked actually on the impact of PopART on inequity in healthcare utilization. We had a question whether actually in the last 3 months, people sought outpatient medical care for themselves. So this did not include impact on hospitalizations, which is a separate study that I'm not discussing today. So it's a binary variable, and it was asked of a 20% subset in each PC survey. It was always a different subset. Then we did also a wealth analysis for our inequality analysis. So, and we used PCA, or principal component analysis, on several observable indicators of wealth or income in order to construct a variable of relative wealth of these individuals in our communities. And then we used something that was developed in the economics literature on concentration curves. concentration curves basically measure the level of inequality in a society. So how does it work? So basically at the horizontal axis, you rank individuals according to their cumulative share of X, which in our case is wealth, the wealth index. So on the left side are the poorest, and on the right side are the richest individual, and you just rank them there. And on the vertical axis, you rank the cumulative share of health burden, which in our case is prevalence of HIV, is the variable Y, and the cumulative share of healthcare utilization. So the likelihood of actually seeking healthcare here would be the secondary variable Z. So actually how this then works, you basically go to this graph, and somewhere here where my arrow is maybe the 20% poorest are from 0 to where my arrow is. And then you go up and you see, when you hit the red line, you say basically that 20% of the population share 20% of the burden if HIV prevalence is somewhere here. But if the distribution looks different, and if it is pro-poor, then we would be somewhere here, and we would say 20% of the population, the poorest 20% of the population, experience 80% of the HIV burden, and that would be pro-poor. If we say 20% of the poorest population share only, say, 5% of the HIV burden, then the distribution would be pro-rich. And then, of course, you can do that for healthcare utilization as well, or for any other measure that you're interested in. So that's basically how that works. Then, of course, then any mathematically minded person will say, okay, when we have that curve, we can calculate how big this area is, and by calculating between the equality line and wherever our actual line is, our actual concentration curve, and then we can derive a quantitative measure of inequality that in itself doesn't mean very much, but starts to mean something if we compare it across populations or across countries. So we use the health inequity index, relying on past literature and health economics in order, I don't have so much time left, so maybe I go quickly through this, but essentially what we did is we tried to measure if the trial had an impact on reducing or increasing any pre-existing inequities. And we did this by taking account of inequality in the distribution of HIV prevalence across our different wealth groups. So taking account of health need, if you so want, interpreted as the likelihood of being HIV positive. And then looking at inequality in healthcare utilization. So any inequality in how individuals responded to the question on how often they visited the primary care facility. And then there is this equation that will allow you to calculate the health inequity index, a quantitative measure of this, first on individual level, but to calculate that we compiled it on community level and then collapsed at triplet level to match the trial design. And in the end, this HII, or health inequity index, is bound between -2 and 2. If it's positive, there's a pro-rich bias. If it's negative, there's a pro-poor bias, and 0 means there's no inequity. So we calculated that, and then we actually looked at how these concentration curves look like for all four, Krista called it waves because she's an economist, but it's the 4 PC surveys, essentially in the treatment communities in both countries and in the control communities, in the standard of care communities in both countries. And what you can see here essentially is that we have a pro-poor inequality in HIV status that is relatively stable over time. So that means the poorest 20% of the population carries more than 20% of the HIV burden. So in other words, the poorer you are, the more likely you are you to be HIV positive, which I don't think comes as a surprise to anyone. So this curve lies basically above the line of equality. However, we can see that for utilization, so these are the basically yellow and red and so lines, for utilization, they lie below the line of equality. So that means that 20% of the poorest population are less likely to go to visit primary healthcare facilities. So there is a pro-rich inequality of healthcare utilization. And then we use the HII for the different ways in order to calculate whether there was an impact of the PopART intervention on how this inequality changed over time. And what we basically found that there was a significant widening in pro-rich inequality in healthcare utilization due to the PopART trial, but only in the final PC survey. So that means that the existing inequity in healthcare utilization, in the sense that the more wealthy ones in our community were more likely to go to the community, somewhat became worse over the course of the trials. So this would suggest that policymakers thinking about implementing PopART should think about suitable interventions in order to engage the poorest in these communities. So let me conclude. Clearly, the economics of HIV is an important topic. I'm bound to say that, but everyone sees that the HIV burden is disproportionately burdening the most productive population groups of societies. It is interesting that HIV/AIDS was the first health issue ever discussed by the United Nations Security Council in 2000. And still today, it's a very important topic for treasuries in low and middle income countries who are concerned about the economic impacts. We are incredibly lucky about the richness of the PopART data that allowed us to investigate many interesting economic issues and develop suitable guidance on interventions that can reduce the burden of HIV on adverse economic outcomes and hopefully contribute to economic growth and political stability. Thank you.